Welcome, everyone. Rush University Medical Center, Division of Nephrology, Renal Biopsy Conference for August 7th, 2025. It's been a minute. It's a tough time of the year. We have vacations, college visits, new fellow orientation, fellow interviews, and the like. Hopefully, we're going to be a little more regular. We've missed you very much, and hopefully, you've missed us. We've gotten some really nice feedback through emails when I tell you that we're not having it this week. So we really appreciate that, and we have a 77 people already. This is almost a new record for us. So thanks for responding to my request to get everybody on. We've got a good case today. There's no CME code. The conference is being recorded. We do have a YouTube channel where we keep all these. There we are. Very nice. This is our new class. The youngest one is not a fellow yet. We're hoping to recruit him shortly, we have nothing to disclose, and we always maintain patient privacy. The protocol is going to be read by one of our new fellows, Dr. Marino. Dan, you want to take over?
Yes, hello everybody. I'm Daniel Moreno. I'm one of the new fellows. I'll get started with reading the protocol. So the patient is a 23-year-old man who was referred to us for evaluation of AKI on CKD. He initially presented to his primary care doctor back in April of 2024 with complaints of fatigue, bone pain, arthralgias, skin rash, frequent nosebleeds, and sinus infections, as well as an oral ulcer. He had also reported numbness of his right hand and left foot, and he saw his primary care doctor and was prescribed 10 milligrams of prednisone, which didn't really help, and he was referred to a rheumatologist who saw him 2 to 3 months later and diagnosed him with GPA based on his clinical presentation and a 1 to 640 C ANCA titer. A PR3 ELISA was not done. His hemoglobin was 8.3, his serum creatinine was 0.69, and he had a UA with negative protein and a trace blood by dipstick. His prednisone was increased to 60 milligrams per day by the rheumatologist, and 2 to 3 months later, he was started on methotrexate 10 milligrams per week. His symptoms improved, but the patient continued to have occasional fatigue, skin rash, and persistent neuropathy for which gabapentin was started. His serum creatinine was now 0.8 milligrams per deciliter, and the prednisone was tapered by 10 milligrams per day per week. He was seen 3 months later at month 5 and found to have a serum creatinine of 1.8 milligrams per deciliter, but no urine studies were checked. He was told to hold his NSAIDs, and 1 month later, at month 6, his creatinine was found to be 2.3. His UA was now active with 2 plus protein and a urine protein to creatinine ratio of 1.05 grams per gram. And the rheumatologist ordered rituximab to replace methotrexate and referred him to our office for further evaluation. His labs were checked at our initial visit 1 month later at month 7 and revealed a serum creatinine of 2.5 with a hemoglobin of 7.8, albumin of 4.2, and his urinalysis had 3 plus protein, 2 plus blood, 0 to 5 white cells per high power field, 3 to 10 red cells per high power field, and the urine protein to creatinine ratio was 1.32 grams per gram with a urine albumin creatinine ratio of 739 milligrams per gram. Rituxan approval was denied/delayed due to prior authorization request by the insurance company, and he was admitted immediately for escalation of treatment and a renal biopsy. So his past medical history, notable for allergic rhinitis. He also had mild to intermittent asthma, and he had an EGD back in 2021, which was done for dysphagia, which ended up diagnosing eosinophilic esophagitis based on biopsy, but it was never treated. He doesn't have any surgical history. His family history was pretty unremarkable. His social history was pretty negative. No tobacco or recreational drug use, occasional alcohol use, and he worked for a project manager for a roofing company, and he identifies as white. His medications at the time of us seeing him, and also when he got his biopsy, were prednisone 10 milligrams per day, methotrexate 10 milligrams per week, and then as needed albuterol inhaler. On physical examination, his blood pressure is notably 134/68. The rest of the vitals are all within normal limits. The patient overall looked and felt well. The examination when we saw him was notably negative notable for an absence of a rash at the time that we saw him. And when we saw him, he showed us this picture on his phone that this is the rash that he had upon presentation to see his primary care doctor and the rheumatologist. And again, this was absent when we saw him in clinic. So his labs, we have a serum creatinine trend over 18 months. We have a creatinine of 0.69 to 0.8 to 1.8 to 2.3 to 2.5 when he finally got biopsied. And his white cells were 11.4, the hemoglobin was 7.5, the platelets were 423 with a normal differential. His chemistry was notable for a sodium of 140, K of 4.8, chloride of 108, bicarb of 22, B1 of 43, creatinine of 2.4 with an eGFR of 38. His total protein was 7.8 with an albumin of 4.2. Calcium was 9.5. His LFTs were all within normal limits. His iron studies were remarkable for iron of 25, a total iron binding capacity of 304, a percent set of 8%, and a ferritin of 30. His inflammatory markers were elevated. He had a CRP of 35 with an ESR of 90. In terms of serologies, his ANA was negative. He had a C3 of 110 with a C4 of 28. His P ANCA was negative, and he had a C ANCA of 1 to 640. His HIV and hepatitis serologies were negative. At the time of the nephrology visit, his C ANCA was 1 to 160 with a PR3 of 0.7. The reference range is listed right here, 0.2 to 0.9. And he had an MPO of less than 0.2 and an anti-GMAB of less than 0.2, both of which are negative. His urine, when we saw him, showed a specific gravity of 1.018. It was yellow, it had 3 plus protein, 2 plus occult blood, negative ketones, 0 to 5 white cells per high powered field, 3 to 10 red cells per high powered field with no casts. And his urine to protein creatinine ratio was 1.32 grams per gram with a UAC of 739 milligrams per gram. A percutaneous renal biopsy was then performed.
Thanks, Dan. Anybody have any questions on the protocol?
Yes, I do, Roger, if you don't mind.
Absolutely.
I may have missed it, but was a CT of the chest done?
It was not.
The reason I ask is that he has a pretty severe anemia. It looks like it's iron deficiency. He has obvious vasculitis, and even though he has a negative, I wonder if he doesn't have occult pulmonary hemorrhage.
Dr. Whitty and I, it's very funny, Dick. Dr. Whitty and I discussed that very topic just yesterday when we were going over the case, but it was not done. Yeah, but you know, the iron deficiency is a big clue, you know, or at least always is a clue for, I know for occult anti-GBM disease. I suppose any pulmonary hemorrhage.
Was there even a chest X-ray?
No. So we actually got pulmonary to see him, and because the negative sat and not even a single cough, they said that no further workup is needed, and that's kind of where we left it.
And I think he was.
I would disagree with that.
Yeah.
And I think you would too, Bill, because a considerable amount of iron can be sequestered in the lung without any symptoms of pulmonary insufficiency or cough, or even hemoptysis in that regard.
Right.
So the pulmonologists have a test that we seldom do called the single breath carbon monoxide uptake, which they do all the time. And it's diagnostic in this disorder. So anyway.
Dick, I'm not a religious person per se, but I can guarantee you, if I were and believed in all this, Dr. Lewis is up there right now applauding you, standing ovation for the 3 things you just said, because boy, he never let those clinical pearls go at a biopsy conference.
Okay.
Yeah, he never would even allow us to get to a bronchoscopy or CT scan. He demanded to what the DLCO was.
Yeah.
Yes.
And certainly jumped all over any iron deficiency. So I think it's a really excellent clinical point.
Yes.
Okay.
Pointing it out.
Dr. Rubin is not here, and I'm thankful that Dr. Rubin's not here today, because this question would probably be the end of him. It absolutely drives him crazy, but we're going to start with a poll. Does this patient need a renal biopsy? And everybody can vote. We don't know who everybody but the co-host can vote. We don't know what your vote is. So please vote. Does the patient need a renal biopsy? Absolutely to determine therapy, or no, not really. The diagnosis is obvious.
There is a question on the chat. Was there eosinophil predominance, Daniel, on the CBC?
Yeah, given the history of eosinophilic esophagitis, of course, after he'd been on methotrexate and steroids, his EOs were normal. But I went back to look at his labs from the first rheumatology appointment, and it doesn't give a percentage on their peripheral smear, but they did have a reference range of EOs of 0.7, and their upper limit of normal of reference range was 0 to 0.5. So slightly elevated, but certainly not 20 or 25% that you would think about eosinophilic vasculitis, or EGPA.
Yeah, and he didn't have asthma either, right?
Yes, he did.
Uh, Yeah, and I think he did have asthma, and
He
he
has some
did.
asthma, yeah.
I'm sorry.
All right, so we can show the results here. This is probably, this is a good representation. We've got 86% says absolutely determined therapy. Only 14% could we talk into. Not really, the diagnosis is obvious. You know, we're moving away somewhat from some of these biopsies if we have enough clinical or serologic evidence. Certainly, you know, in PLA2R positive membranous, we're probably not biopsying most people. And there has been people that have written the argument for not as necessarily needing a biopsy for all ANCA positive renal disease. But having said that, 86% still say yes. Let's go to the next poll. I think it's the next slide. So if for whatever reason you could not get a kidney biopsy, how would you treat this patient at the present time? A, increase the dose of methotrexate and increase the dose of prednisone. Number 2, steroids and rituximab. Number 3, steroids plus cyclophosphamide. Number 4, steroids plus cyclophosphamide plus rituximab. Or 5, steroids plus either cyclophosphamide or rituximab and add avacopan to it. There's other permutations, but it gets a little crazy if you go too far, so. Votes are still coming in here. That's probably good. Increased dose methotrexate, increased dose prednisone. Nobody fell for it. I'm proud of you guys. So it's actually kind of interesting. There's not a real mandate here. There's a slight preference for 5, which is the use of adding avacopan. But there's a mixture of just about all 4 of them, the lowest being steroids and cyclophosphamide, which is interesting too. We can talk about, you know, if there is a role, forget about avacopan for the time being, but if there's a role for preferring cyclophosphamide over rituximab as a primary therapy, and if there's a reason to based on someone's clinical presentation. Let's go to some faculty discussion. I want to ask Dr. Gashti, fresh from Africa. Hopefully you're not having rigors at the present time. Casey, hope you're feeling well. Just back from a 2-week safari. Casey, what do you think's going on, and what do you think some about these poll questions?
Thanks, Roger. Just jet lag. No yellow fever, no malaria. I'm good.
Okay, that's good. We need you desperately.
So yeah, I do think that it's you know, the serologic markers and the rash and the neuropathy and the anemia, they're all kind of consistent with vasculitis. It does you know, support that. You know, the first poll question was, do you biopsy this patient or do you not? And you know, I'm going to go with the minority here. And you know, yes, I'm sure it's going to give us some degree of fibrosis and maybe some prognostication as far as, you know, what to expect, but it's probably not going to change the diagnosis itself. I think it's just going to still show a potentially like a post-immune necrotizing and crescentic glomerulonephritis consistent with the clinical picture of vasculitis. From a treatment standpoint, I do like since the patient was already on high dose steroids plus rituximab and they continue to progress, and rituximab was delayed or not, or
Sorry, they were on
ever get rituximab?
They were on high dose steroids and methotrexate.
Okay.
He had not received any rituximab yet.
Okay.
Yeah, the poll is really what would you do first after, yeah, you don't have a biopsy and he's methotrexate.
No, I would definitely not do methotrexate anymore, especially with in acute kidney injury and the fact that the patient's creatinine is now going further higher, and you know, despite high dose steroids, I would probably go with option. It's really not wrong to do 2, 3, or 4, or 5 for that matter. I would probably pick, because it seems to be very aggressive of a disease, I would probably do option 4. I would do steroids plus cyclophosphamide plus Rituxan. That's sort of, just to kind of throw the kitchen sink because I feel like he's young, and if we have one chance of calming this thing down, we kind of need to kind of go all in as far as immunosuppression.
Yeah, that's what's been reported. It's never been compared. It just they've the group from Niles from Harvard have reported their use.
The
Uh,
rituximab.
yeah, triple therapy,
Hmm.
and they've done it for membranous, and they've also I recently saw their triple therapy for C3G. No, for three C.
They
Yeah,
did.
C3.
They've done
Yeah,
it for
C3G, right.
fibrillary.
Oh, it's February. Okay, thank you. Yeah,
Fibrillary, but they
yeah.
they
I'm sorry.
basically
Thank
use
you.
that as a protocol for everything.
Yeah, I mean it's kind of interesting. They just kind of go ahead and do it, and then they report the results. So yeah, I like what you said that 2, 3, 4, 5. You probably. I mean, we can argue, but I think none of those are a bad decision. You know,
Yeah,
and
I mean, the
think
5 is the addition of complement inhibition is, if we're thinking ahead of time saying, we want to do steroid sparing or steroid reducing regimens, then I think we can think about that. But I think this is a really young person, 23 years old, with a creatinine of 2.5. I suspect there's going to be a significant amount of inflammatory changes on the biopsy, and I am not at this point thinking about steroid sparing. So maybe at some point I can add a Vacopan later, but I'm not sure if that's my number one focus at this point. My number one focus is preserve kidney function.
Dr. Rajasekaran, sorry. What would you do?
Yeah, thank you, Roger. I think that the question is, what would I do without the biopsy right now? Correct? I mean, we're not having the biopsy
Yeah, because
or
we
in
don't
a
have the biopsy
situation.
yet. Right.
Yeah, so I would choose an option little different, which would be steroids plus rituximab plus avacopan. And my rationale for using that regimen would be that this patient is presenting with a PR3 or a C anchor related uh, positive immune vasculitis with systemic features. Now we know that the PR3 titer is very low, but that really should not influence decision or medical management because we don't even use the anchor titers in the BVAS score. So this patient is coming in, he's having significant kidney function loss. And what we do know from the P anchor pathophysiology, the C anchor, which is the PR3 anchor, is that these patients respond well to rituximab, but then relapse frequently, needing more rituximab. So yes, it may not change my management so much. I mean, I can still give the rituximab and then wait for the biopsy, but I would like to use avacopan in this patient as a steroid sparing agent. The only difference in the treatment protocol was that in those patients in the advocate study who got a background of rituximab, they were not allowed maintenance. Meaning for 1 year, they got the 4 doses of the RAVE protocol initially, but did not get a 6-month dose of rituximab. So I would probably add that 6-month dose of maintenance rituximab and continue the avacopan. Because the cyclophosphamide arm in that study got azathioprine.
That's the devil's in the details, and I hadn't realized that. It's a good point, but especially with, as you point out, with PR3, you really want to, you really don't want to get complacent with that and let this disease jump back at you. I think that's your point, right?
Roger,
Yeah.
if you read the fine points of the paper in the New England Journal of Medicine that led to the approval of avacopan for vasculitis, there was no improvement in the rituximab treated patients. All of the benefit was seen in the cyclophosphamide treated patients. It's a post hoc analysis, and it's not proof because the randomization was not stratified by rituximab or cyclophosphamide, but the post hoc analysis of the responders, they were all confined to the cyclophosphamide treated group. I just want to point this out.
No, I think it's
because
a good point. Let me ask you a question, Dick. I mean, this sounds clinically like a pretty bad vasculitis going on here. It's an RPGN. It sounds pretty bad. Just look at the option 2 and 3. Forget about avacopan as part of this. or two, 3, and 4. Let me ask you this: if you only had the option of 2 or 3, given that this is pretty bad, do you believe that cyclophosphamide is a better therapy for a very bad vasculitis over rituximab? Would you choose that?
No.
You would not. What was your
partly for the reason that was just mentioned? PR3 vasculitis is really better treated with rituximab. Fewer relapses and the outcomes are better. So I prefer rituximab for PR3 vasculitis based on partly observational trials, but and retrospective analysis of the published control trials.
Well, let me ask you this. Let's say you're only given option 2, 3, or 4. What would you choose? Steroids, rituximab, or steroids?
That is a difficult one because we don't have controlled data.
We don't even have a
and
biopsy.
as you pointed out, I understand the rationale. He's young, treatment has been delayed, he's been not treated appropriately, and you want to do everything you can for this young man. So adding a short course of low-dose cyclophosphamide for me is kind of a no-brainer. It's only 8 weeks. It's 1.5 milligrams. The side effects are minimal even in a young man. So long-term sterility is not an issue. I would probably go with Casey and give triple therapy.
Sounds good. Let's move along. What you brought up, this being delayed, is a very big part of this case, and I think probably Dr. Whittier will walk us through his thoughts on that a little bit as well. I think, where are we? Ready for pathology? Let's see. Yeah.
So we did do the biopsy, just to defend it here, considering this is biopsy conference. But yeah, I wasn't really expecting to see anything other than a polyimmune GN. But what I really, really wanted to know was, is this already dead and burnt out and gone, or is there still enough activity there that we could still treat with something? And so, 2.5 is a pretty bad creatinine. And I just wanted to see how much chronicity was there, because if it was all still active and no chronicity, then maybe I would even do plasmapheresis and hit him with everything. And if it's all scarring, then maybe I do something a little bit more lame. So that was sort of my thought process to how the histology was going to affect my therapy.
Yeah, and there is another report that's not where I don't know if it was quadruple, but certainly a plex was added to everything, and I think it was also out of the East Coast somewhere. So, Pravir, can we put up the live wheel? There we are. Okay. Oh, by the way, the fellows are going to be off the wheel for a while. We have new fellows, so it's going to be double up with the faculty. I have a wild card. Anybody that's of our co-hosts, if you ever want to be put on the wheel, by all means, let us know. I wouldn't ask you to, but Arun or Dr. Reed, anybody wants to be on the wheel, we'd be happy to put you there.
Yeah, I'd be happy to have one less piece of that pie if anybody else volunteers for it. I think I see 3 of me up there. I'm not sure that you. How? Of course it lands on me. I can read it.
I'll spin one more time.
Okay.
Dr. Gashty. That's good because he discussed it.
Okay.
All right, give me a second here. I'll give you control. No control. All right, go ahead and click on the screen. Yep, that's you.
Great. Okay, so the first slide is a high power.
Actually, low power.
I'm sorry, low power trichrome. I'm sorry, of 2 cores, and or many glomeruli, but lots of them actually look completely hyalinized. Like I see sclerotic glomeruli, so all these blue circles are essentially dead gloms. And if you look at the tubeinterstitial space, I would say if you put both of them together, over 50%, I think tubeinterstitial fibrosis.
Yeah, I estimate about 75%.
Okay. And this artery, I'm sure we'll comment on at a higher power, but I really see a few glomeruli that are not completely gone. So already pretty significant damage. So this is a high power H&E. We have, I'm trying to see. Obviously, we have a glomerulus here, and then I'm trying to think if this is another glomerulus or if this is like a
Ye-
blood vessel.
Yeah. That's a glomer. In the center is what's left of the tuft. It's scarring
Oh,
over.
so this is
And
just the way it's cut.
yeah,
Okay, so
yeah,
this is like a crescent, correct?
yeah,
Almost a circumferential crescent with
yeah.
a glomerular tuft being obsolescent. But the one that's viable, I don't see any in this particular tuft. I don't see any areas of necrosis. I don't see any proliferation. I don't see crescent. So this one looks good. There is
David, is that all fibrin in that one crescent, on that one glom, what's left of the glom?
On the one on that there, I
Yeah.
think that's fibrin transitioning into to scar.
Yeah.
Yeah.
David, is all that interstitial nephritis just, I'm sorry, somebody's going to comment on it. Is that all interstitial nephritis just related to this dying glomerulus, or is that, do you think it's a primary process?
And I don't think it's an independent process. Yeah, I think it's related to all the glomerular injury. This is one of the few healthy glomeruli that we'll see in the biopsy.
Yeah, I was going to say there's a pretty dense infiltrate of mainly lymphocytes, but some plasma cells that are probably related to the inflammatory process that we're seeing. All right, the next slide is also an H&E, and we see the glomerulus that's at the center. There is there we see a crescent, so there's these bluish kind of nuclear cells. That's the crescent. The tuft itself is smushed in the middle, but I see endocapillary. Essentially, you can't really see open glomerular or capillary lumina. So this is a very inflamed glomerulus, a crescentic glomerulonephritis. Again, you see the interstitial infiltrate around it. The tubules, we see there's one tubule here, some loss of brush border. The artery that's next to it here, I don't see any arteritis. This fibrin piece on the bottom is probably part of an obsolescent glomerulus.
Yep.
Here's another H&E of a glomerulus with significant inflammation and too far gone. Obviously, the tuft itself has undergone fibrinoid necrosis. There is a crescent around it. There's periglomerular fibrosis, and there's a periglomerular interstitial infiltrate as well. With some, I don't know if this is artifact, but there's some degree of ATN. I see a little bit of tubular injury here.
Right.
This is a PAS. Can see the Bowman's capsule, and there's a rupture here at about 1 o'clock or 12 o'clock. I feel like the GB or the Bowman's capsule is disrupted, and I see some inflammatory cells that are kind of communicating from outside to the inside. So this crescent that's on the left side of this particular nephron looks like it's kind of like broken the Bowman's capsule, and there's very little left of the actual tuft itself. So it kind of really just shows you the same thing that we saw on H&E.
Yeah, and then
These
normal.
tubule, I'm sorry.
Oh, go ahead.
The tubules, the basement membrane look wrinkled and thickened, so this is chronic tubular injury.
Yep.
Another glomerulus, same thing. This one is even further gone. This is essentially like hyalinized glomerulus.
Yeah, even kind of segmental scarring. You have a few open loops over to the right, down a little. Yeah,
This
little bit
area has
there.
some open
Yeah.
loops. This area
Yeah.
is a
Yeah.
big segmental scar. Yeah.
Yep.
This is a Jones stain. So essentially what we saw, I'm looking at the staining of the Bowman's capsule, which is again disrupted here at about 10 o'clock. So there are some pieces of basement membrane. I don't see any spikes or holes, nor did I expect to see them. So this is, again, same thing. Severe crescentic glomerulonephritis, well, the post-immune part, I have to wait until the fluorescent. This is a little bit of a higher power, which essentially shows us that the 6 or 7 glomeruli that we see, they're all hyalinized. And there's
Yeah,
pretty significant, yeah.
to 25 of 33 glomeruli in the biopsy, 75% globally sclerosed like this.
Okay. Again, you see a pretty dense, I don't know, this feels, I guess we see interstitial infiltrate with these inflammatory GNs, but this seems a little just more dense and just very obvious. So I'm sure this is part of the same process. I'm not implying that there's a separate interstitial nephritis going on, but this just seems like a lot. And I don't see eosinophils. Actually, I do see a few eosinophils here, but I'm not sure if that's specific for anything else.
David,
Yeah.
since this biopsy was done for prognostic and therapeutic purposes, not a diagnostic biopsy, wouldn't it be appropriate to say to the clinician, what is the percent normal glomeruli? Because the literature now suggests that the percent normal glomeruli is the best prognostic indicator.
Sure. Yeah. If they ask me, I'm happy to provide that.
Well,
Let's
I
see.
usually tell the pathologist, I want to know what the percent normal glomeruli. I don't
Okay.
care about interstitial fibrosis. I don't care about hyalinized glomeruli. I want to know the number of glomeruli that are normal in the biopsy. So in this case, it's under 10%, isn't it?
Yeah.
Yeah. Very bad prognosis.
Yeah, because we've got 75% sclerosis, that leaves 25%, and basically you showed one normal glomerulus.
Yeah.
And a
Yeah,
lot
the
of
others
segmental
have-
necrosis and crescent, so yeah, it's gotta be under 10%. Great point.
Yeah. A few had segmental scars. That leaves 3 out of 33 that were completely normal.
Well, I was going to ask Dr. Whittier, he did the biopsy for prognostic purposes. Now he's got the biopsy and it's a very bad prognosis. How does this influence his decision in treatment? Is that the next question you're going to ask, Roger?
Yeah, that is the next question, Dick, so.
Okay.
Answer choice E is place a fistula.
Okay, so this one is really, this slide is, I'm sure, meant to indicate that this patient has many red blood cell casts that are seen in the tubules.
We can never find them in the urine, so we have to show them on pathology. I'm not proud of that, by the way.
Yeah. It's kind of interesting how they're all in this. I mean, I'm sure this is the same tubule that's cut in different ways.
It's
It
probably
would
the
be
one,
odd.
the
Yeah,
one
it's just
glomerulus that's
one
not,
tubule that's cut this way. Otherwise,
right,
it would be
it's the
very
one
strange to
glomerulus that's
have
working.
concentrated red cell casts in just one area.
Yeah.
We stopped finding red cell casts when Dr. Kark stopped doing the phase and millipore analysis here.
Yeah.
So immunofluorescent is negative for IgG, IgA, IgM complements kappa and lambda, as expected. Electron microscopy, here we have a GBM, we have the urinary spaces on the outside, blood spaces on the inside. Here's the endothelium that's inside here. The podocytes are out here. I'm looking for, I think these podocytes are pretty severely damaged. I don't really see that they're even sitting on top of the GBM. So the comment on podocyte foot process effacement, I think is just irrelevant in this case. I see some things here, but I'm not sure if this is just part of a damaged podocyte. David, what do you think?
Yeah. I think the amount of podocytopathy is kind of irrelevant, but yeah.
I don't see any deposits, electron dense deposits in the mesangial area, nor do I see any in the loop.
We're lucky to have a normal, a lumen, considering how few
Yeah.
glomeruli there were on EM. So your
So-
histopathic diagnosis
Is a post-immune crescentic glomerulonephritis with severe both glomerular and tubular interstitial fibrosis.
you know, I said if anybody else wants to be put on the wheel, let us know. Casey, you just set the bar so high. You know, that was incredible. I gotta say, and I'm bragging about our group and the history of us in pathology, but I'd like to find a non-renal pathologist that could read it better than that. So applause to you. It was a great read. You probably intimidated our fellows too, but don't worry, we'll train you. So we have another poll now. Poll number 3, the biopsy results change my treatment decision? Yes or no? And these are what the decisions were before, what you could have picked one of those. So let us know if the biopsy did change, because this, as was pointed out, this was really not about a diagnosis. This is about prognosis and if it would have an effect on what you would do.
Pretty good.
Yeah, that's good. So we have about 60% said yes, 40%, 38% said no. Let me hand it over to Dr. Corbett. Steve, did the biopsy change your treatment decision?
Not really. I mean, the problem is what it did confirm is how poor the prognosis is for this patient, probably almost no matter what you do. I mean, I still think you need to treat with what you believe is going to be the most effective therapy in this kind of dismal situation, whether that be rituximab or cyclophosphamide. But unfortunately, I'm sure as will come up here, the prognosis is horrible when this percentage of glomeruli have globally sclerotic gloms and there's so few remaining normal cells or normal glomeruli.
Dr. Reen, did it change your opinion at all or your mind?
Actually, I'll treat this patient not for kidney disease itself, vasculitis and all the other organs also, such as heart and all those things. For that reason, I'll treat him, but I have no hope in his kidney. So I'm not treating his kidney disease, but I will treat other manifestations of the vasculitis.
Well, if you remember, he felt pretty good after a while, but then his creatinine started going up. I mean, a lot of his systemic symptoms resolved. His rash went away. He felt a lot better, and then just kind of, and that was part of the problem, is that he felt good, and I think that delayed looking and realizing the importance of his renal disease. So, you know, sometimes steroids alone will treat the symptoms of vasculitis.
Part of what comes out of this, and I know you had alluded to the fact that Bill's going to get into this, so I don't want to get too thick into the weeds on it, but you know, this guy's PR3 titer, or not titer, but his level was high, right? It was 30.7 or something when they checked it.
No,
Less than 0.9 was normal.
I thought his PR3 level was normal.
No, actually, we never. So they never had one initially. All they did was a.
No, I know, but I thought in the protocol later on there was looked like 30.7, unless it was 3.7. Either way, normal was 0.9.
No, his
PR3, what is that? Is that a 30 or is that a 3?
0.7.
The PR3 is 0.7.
Oh, I'm sorry. You know what? My bad. My bad. I'm getting old and misreading things. But either way, I think the issue here is this shows you how this can be really rapidly progressive, and your window of opportunity closes fairly quickly.
You know, they had the C-ANCA, but the rheumatologist never did get a PR3. And then by the time it was checked, he'd already been treated with steroids. So really, we don't even know how high it was. And I don't know how important that is prognostically or whatever. I mean, it would help us as a marker, I suppose. But it's really a shame that that was never done, that we never had an ELISA. Arun, what does this change your opinion at all?
Not really. Not really, Roger. I think that this is because just like Dr. Reen has mentioned, it's a systemic disease, and he's got severe ANCA-associated PR3-related vasculitis. So I would still treat with steroids and rituximab, but not have too much optimism for his kidney function.
So Rune, let's say that it was 80% crescents and all AKI and no scarring, versus what we have here. Would you treat those two biopsies differently?
I will honestly admit, Bill, I would probably have said yes before, but now I think I would have treated them the same. It's just the data on the use of these agents. I don't think I would have done anything differently. I would have still used, I would not have used rituximab with cyclophosphamide. I would have just, because the creatinine, if you look at the older studies, the cutoff was 4. This patient's maximum creatinine was 3. Agreed that we don't have the biopsies. This patient is completely fibrosed. But I would still use, not use combination. In other words, rituximab, but I would still add avacopan
I mean,
to treat the systemic vasculitis.
you could look at it two ways. You could look at it, oh, it's just so far gone, or you could also look at it, oh my God, we better do all we can to keep him off dialysis. I don't know the answer to that. Dr. Reen has his hand up.
I can share a patient of mine who's a 23-year-old guy who actually presented with creatinine of 1700 in our Canadian journals. It's pretty high. So he was dialyzed right away, ANCA positive. Kidney biopsy was done while he was admitted by another nephrologist, and it was 70 to 80% fibrosis. So we elected not to treat him, but he will come about a month after he came with severe pulmonary edema, injection fraction at 25. So we ended up treating him, and actually we were able to get him transplanted quite early. So I will, although in this case, what you described looks like similar patient of mine, and I will actually agree with Dr. Arun that this patient should be treated despite the kidney disease because you have to prepare him for transplant. He'd rather be healthy than sick.
Well, this gets back to what Dick had brought up as well. I mean, was there ever an evaluation of his lungs to see how active the pulmonary process might be? Because as Reen was alluding, the extrarenal disease may dictate the therapy more than anything else at this point.
I think that was asked and answered, and I'm not trying to be rude, but we asked pulmonary and they kind of poo-pooed it. So
no, I know that was originally, but I didn't know if Bill followed up and did it independently at some point later down the line.
No.
This case is tough because they see this guy, he's got clinical disease, it's screaming GPA, and yet his urine's essentially normal, and he kind of treats him a little bit, and then suddenly things start taking off in the kidney, and then there's a big delay before it actually gets sent to Bill. And I think we're seeing, the results of that in the biopsy is pretty impressive. I want to hand it back to Dr. Whittier, and he can tell us, what his thoughts were. I asked him to talk a little bit about avacopan and what the data is, and what his thoughts are about all this. So.
Yeah, sure. So thank you. Do I have the screen?
Yeah, here, let me give you control. Go ahead, click.
So just like we were saying here, this is just sort of the data behind the degree of sclerosis and how that's associated with prognosis and on the biopsy. And we were certainly here with quite a few that were sclerotic, or a lot less that were normal. And this is really how they did. This is where our patient is following in the severe sclerotic category. But if I could just be on a soapbox for a second, it's just a shame that we, at some point, should have been able to get him when he was either here or maybe here. And I just implore anybody really that's here that's not a nephrologist, that if you see even an abnormal urinalysis or amount of protein before it even gets to the creatinine going up, and somebody with a known disease that can cause an RPGN like lupus or leg vasculitis, that really the sun shouldn't set before you picked up the phone and called a nephrologist. Even though the patient was on therapy for systemic vasculitis, it clearly wasn't doing the job, and I just wish I would have gotten to this patient sooner. So we talked about a lot of the therapies. We didn't really go into Pexavas here, but I think that the real reason I was doing the biopsy is because if all those 80 or 90% of glomeruli were active crescents, even though they would be heading towards dead glomeruli, and they were active crescentic at one point likely. I think I would have done something a lot more aggressive for treating him actively. Like I might have done plasmapheresis plus cyclophosphamide plus rituximab plus even avacopan. Or I wouldn't have done them all, but or if it's all scarring, maybe you can do a little bit less. And so that's one of the reasons I did this. And even though this was a negative study for plasmapheresis, what's actually come out of this is several things. One, you can get away with lower dose steroids, which is a really nice option for people. And two, there are some times where we still do want to consider plasmapheresis if it's severe alveolar hemorrhage, possibly. Especially if it's oxygen requiring, then you may want to think about that. If it's dual GBM and ANCA positive, you're certainly going to want to consider plasmapheresis. So there's still times, even though this was a negative trial, I think that there's the data on using plasmapheresis for ANCA vasculitis is not really dead. So what about avacopan? Well, the complement pathway is sort of listed here. And avacopan is the complement blocker that blocks C5a, and where you'll find that in vasculitis is here, where we're going to have our C5a that attaches and primes these, and these are then able to cause all this damage. And so then if avacopan can block that, it can really block the priming of our neutrophils. And this was the study of avacopan. This was a year after the Pexavas style study. And we've already mentioned this, but it was patients that were randomized, there were 330 of them, and they were randomized to either this steroid group or the avacopan group after they were either randomized to cyclophosphamide or Rituxan. And the data at 6 months was non-inferior, but the data at 1 year was that avacopan actually had a little bit improved for sustained remission at week 52. So it's really only been studied in these steroid-sparing patients, but that's an important therapy that we should really be thinking about for our patients. And you might have thought, well, gosh, this guy, he's too far gone. He's got a really bad GFR already. He's got a lot of scarring on the biopsy. That's not exactly the patient that we want to go put on a newer therapy that only has 1 year of data in clinical trials with limited follow-up. But this was a very interesting post-hoc analysis where they looked at patients who had a GFR that was low at less than 20. Of the initial 330 patients, 50 of them were here. And what you found out here is the group that received avacopan actually had an improved GFR over time, even if they started with such a low GFR compared to the group that did not get avacopan. So a low GFR is not a reason to not give avacopan. But what we don't know is in patients that are on higher dose steroids, if there's any extra benefit. We really only know it as a steroid sparing agent. And this is just kind of some real world data there on avacopan that we don't need to really go through, but shows that it kind of works. So since avacopan is a complement blocker, and since quite a few of these complement blockers are now on the market for different glomerular diseases, I just wanted to go over some of them to give an idea of how I remember them all, which I don't do a great job of memorizing new things as I'm advancing in my age. But we've got our alternative pathway, remember, which is always on. And then we've got our classical and our lectin pathway, which really arises to threats in our immune system. And here's a lot of the different complement blockers that are out there. Now, I think there's 14 or maybe 16 different complement blockers approved by the FDA at the present time. And not all of them are for renal disease. There's PNH, there's inflammatory bowel disease ones. There's a whole bunch of other ones that are not really related to ours, but the ones that we are in our realm that we are really aware of is iptacopan or Fabhalta, which has recently been approved, and that's for treatment of IgA nephropathy, of course, but also for treatment of C3GN. Avacopan that we were talking about today with vasculitis. Eculizumab, which was one of the first ones that we had exposure to for atypical HUS, or now it's called complement-mediated HUS. And a lot of these, if it ends in MAB, of course, that's a monoclonal antibody. But the complement blocker ones end in either copan, or if it's a pegylated one, it actually ends in coplan. And the other nice thing about the way to remember some of these, not all of them, is that the first letter of the drug is where it's blocked. So you see copan and it's a complement blocker. And if it starts with a D, it's hitting factor D, okay? If it's avacopan, it's a complement factor with copan. If it starts with an A, it's hitting our before C5A. If it's eculizumab, I think of it as hitting everything because it hits the membrane attack complex at the very end. So that's how I remember that one. If it's a coplan, that means it's the pegylated one. And that's the one that also would start with PEG. But you can see here it's pegylated, and then it's going to hit factor C for a cetacoplan. Okay, so again, it starts with that same letter. So that's the way that they've sort of named them at least. And then, of course, there's other cool names, like this is a FAB inhibitor, iptacopan, okay? So it's factor B. So they called it, HALT factor B, Fabhalta. So it's a little bit of a way to remember some of these because all these new drugs are coming out here and it's hard to remember where they work and how they block the different complement system. And we're basically going to become complementologists, I think, moving forward because there's going to be so much, hopefully, data that drives use of blocking the complement system for a lot of our different GNs in the future. So anyway, the take-home points here for this case and what I actually did in this case was I think that if I really did see, so as opposed to what Arun said when I asked him the question, if I really saw all active crescentic disease without scarring, I very likely would have hit him with plasmapheresis, and I would have either gone with rituximab and cyclophosphamide, or I would have done rituximab and avacopan. Okay, I think that's kind of what I was thinking for very aggressive disease. Because I know now that he is going to have a lot of immunosuppression in his future in terms of transplant therapy, in terms of even dialysis, some consider to be an immunosuppressed state. I leaned against aggressively hitting him, knowing that he's already so scarred. And his systemic disease had been pretty well controlled by the time I saw him. So what I decided to do was give him rituximab, and I had given him IV Medrol before the biopsy, just in case. And then we treated him with a low-dose Pexavas protocol of steroids after we gave him the initial IV Medrol. And so far, it's been a couple months, and his creatinine is about 2.2 from a peak of 2.5. His hemoglobin, interestingly, has come up quite nicely, up to 11 or 12, which means to me that he really likely did have either he was so sick and his hemoglobin was low because he was just so sick, or more likely, I think this rituximab might have actually improved some subclinical alveolar hemorrhage that he might have had because his iron deficiency went away and his hemoglobin is now back up to 11. So, and his creatinine is not an enormous amount better, so you could argue that it's not necessarily just CKD edema. I think there really was something there in his lungs as well. But luckily, Rituxan's kind of handled that too. So if we look at our different treatments of vasculitis from KDIGO, I think the initial treatment here, there's a lot of different options, and they were all discussed today. And so I'm glad you can do cyclophosphamide or rituximab, okay? You can do, both. We can add in avacopan when we want to do an alternative to glucocorticoids. I think that I learned from this case that even if the GFR is low, there actually may be even more of a benefit. So you could argue that this case really could have used avacopan just based on the GFR data alone. Although I just think he was so scarred that he may not have really responded to too much. And there are still times to consider plasma exchange. Just beside severe GBM disease, that's concomitant or besides severe alveolar hemorrhage. And I think we can get away with lower dose glucocorticoids as well. And so that's kind of what I was thinking about for his induction. I gave him Rituxan and steroids, and so far he's at least stopped getting worse. Remember, for the last 18 months, he was just getting worse and worse with his creatinine. So now I've stabilized that. He's come down to 2.2. And hopefully if I halt him there, he can have a couple good years being dialysis free and being off transplant.
Bill, I love your term, we are now complementologists. I'm going to use that. Do you think with all these different complement inhibitors and different parts of the complement pathway, do you think there's a reason why avacopan was chosen for vasculitis, or was it just the drug that they had?
Go ahead.
No.
There are all of these different ones here. Can you see my screen? I'm still sharing, right? Oh, maybe I'm not sharing anymore. Okay, that's fine. I can go back. Yeah, that's okay. Thanks, Praveer. Yeah, avacopan was clearly studied there, but if you actually go back, there was blocking C5A. Go back a couple slides to where there was where it would work before the abstracts. Yeah, that's it. So see where Avacopan works there, Roger. Works if you look up at the symbols up there, where
Okay.
C5A attaches. So I think that was the main reason, because they were worried. They knew that C5A was implicated in priming the neutrophils, and the primed neutrophils were such a major issue with this T cell, post-immune mediated destruction, vasculitis. So I think there's data on using each of the complement blockers at very specific spots, and I think in C3GN, for example, there might be some people that have a C4 nephritic factor or a C3 nephritic factor, or there's different ways that I think that hopefully we can get to the point where all of C3GN is not treated just with iptacopan. That the iptacopan is going to be the one that hits that specific spot of the complement cascade, and then you're not needing to block it further down. I think that's the hope for the future, that we biopsy somebody, they have C3GN, but then we're using their genetic or their measurements of their alternative pathway to narrow down which drug they will respond to best. So I think there's specificity in the future that's going to help us. We don't have that now.
Yeah, that's a great answer, and I'm glad you brought it to this slide, because you look at all these different everything's the new kid on the block is everything's now complement mediated. IgA, everything is complement mediated, and before it was just kind of a marker. We didn't really I think understand it, and there's going to be all these complement blockers. And I don't think that everyone's going to study for every disease. So I just hope that, like you said, it's precision medicine, and it would kind of make sense to take this one for this pathway, this one for this pathway, and that we can kind of, we don't just pick the one that's easiest to get. So I think
it's certainly a lofty goal. It's a lofty goal of mine. I hope it gets there.
Pardon?
That's a lofty goal of mine that I hope it gets there. We go from the days of prednisone destroys everything as far as immune mediated to just more specificity with time.
Well, it's incredible how far we have come. I mean, it used to be prednisone and mustard.
Nitrogen mustard.
Mustard. I mean, and then I mean, it's just really incredible. And I think we're seeing the beginning of exactly what your wish would be. I'm going to wrap this up. Does anybody have any more comments? I'm sorry.
Yeah, I just wanted to comment about Avacopan. Bill, nice review. We need to remember that Avacopan is a receptor inhibitor. It inhibits the C5a receptor. It does not affect the generation of the membrane attack complex. It doesn't affect C5 convertase. It doesn't affect C5 itself. That's why immunization is not required for the treatment. It can be used immediately without any immunization, and its effects are quite reversible. As soon as you stop the drug, the effect on the receptor goes away. It has no permanent effect. So, I mean, it's ideally suited for a disease which you need to treat right away and not bother about immunizations. So in that sense, it finds a real niche in the treatment of aggressive, rapidly progressive glomerulonephritis, where you need to make a decision that day. I mean, time is nephrons. We've heard that many times in this conference, and I can't tell you the number of times I've seen doctors delay treatment until they could get tissue. No meat, no treat. That's bad medicine. I mean, if you think you have a drug that will help a patient and you think the diagnosis is correct based on clinical information alone, please don't wait for a biopsy. Treat the patient. And I tell you, I see this over and over again, particularly in countries where it's difficult to get a biopsy, not like it is here. I mean, it may take weeks to arrange for a biopsy. And to sit on a patient like this for weeks is just not a good idea at all.
And we've seen the result of that in the biopsy and the creatinine. And I think Bill feels lucky that he's not on dialysis. And but yeah, I don't know that I've ever heard Dr. Glassick be so passionate about anything. So take it.
Just a word of Dr. Radvi, just a word of caution about Avacopan. I learned it by hard way. it has a lot of interactions with other drugs. So make sure you know that, like grapefruit juice and statins and all those things. I think it works with chromosome 450 or something like that, cytochrome 450. So be aware of the interaction of this drug. We use it quite frequently and quite early. Just to remind.
Are
I
you,
like that. I
are you
like
using
the
it pretty much, Dr. Reen, are you
Sorry.
using it as, are you using it as default in a vasculitis, pretty much everybody?
Almost everybody.
Interesting.
I like the no meat, no treat. I'm gonna have to write that one down.
The tissue is the issue, is the
Yeah,
one.
there you go.
Yeah. I'm going to wrap this up. Great discussion. Great read, Casey. Great discussion, Bill. Thanks, everybody. I think we're going to be college visits next week, but we'll be back in 2 weeks for sure. But follow your email. I want to thank so many people for coming today. We've been off for over a month, and we had a new record of 90 some people. So thank you so much. And until we're back, everybody, stay safe.